so I'm going to talk a little bit more about the research side of what we do. Some of this will overlap a little bit because obviously what we're trying to do is to bring the research into the clinical space, and so some of the things that I was talking about in the first talk come directly from the research that's been done. So if we go back to the very beginning, there was one or not very many at the very beginning. So you've met Bex, who essentially came to see me one day in the clinic, my general cardiology clinic as it was in those days. And we were talking about SCAD, and she said, what research was being done into this condition. And I said, Bex, SCAD, it's very rare. You'll probably never meet another patient who's had SCAD. Myself, I've only seen a couple in my career, and it's just one of those very unusual things, I said. And she said, that's funny because I've already got a bunch of Facebook friends who've got SCAD. And because I'm an academic, my little sort of academic radar started to go off to say, that sounds like a cohort. I also just wanted to highlight not just the sort of, the small beginnings to the big room and the amazing things that Beat SCAD have done to achieve that, but also to talk about the guy on the end who's Rajiv Gulati, and also the team at the Mayo Clinic, particularly Sharon Hayes and Marissa Tweet. Because SCAD research and SCAD as a whole, it's a collaborative endeavor, as you are hopefully appreciating if you didn't already, which is that, I can dream up all sorts of research ideas in my man shed, but it's no use if I only have 5 patients to do my study on. We're not going to learn very much. And, it applies both across clinicians in terms of setting up our new clinical services, across research in terms of using expertise that I don't have. My exercise, as you can probably tell, rehab knowledge is not as good as it ought to, particularly after lunch, of course. But yes, it's a very important thing. And so we set up the SCAD registry. This shows you what websites used to look like. Do you remember these websites back in 2011 or whatever it was, 2013? So it is key. It made a massive difference to us at the very beginning that the Mayo Clinic, which is a kind of amazing place. I have actually now been to visit them in the Mayo Clinic. It's like half the city is made up of the Mayo Clinic. It's an incredible place. But it made a big difference to us at the time that they were interested in our ideas and wanted to support us to set up SCAD research here. And again, it's that kind of outward-looking, collaborative undertaking that's so important with this. And you can see, subsequently we now have a European study group and a European registry that's been begun. There are a few names here, but also even beyond the kind of clinical care NHS side, AstraZeneca, they ultimately funded the first stage of the genetics research that I'm going to present, and they've funded that altruistically. All of these people, I've got people from France, from Australia here. Jacqueline Saw definitely deserves a mention, another of the doyen of SCAD research, with Sharon Hayes really establishing it. And, particularly in some of the genetics research that I'm going to present to you, the fact that all of these people said, do you know what? Yeah, we're going to bring our genetics research together into an international effort to try to understand the causes of SCAD. It's unusual. There is not anybody in the world who is interested in this disease that did not participate. Nobody said, I'd rather do it on my own. And you'd be surprised in research how often, that is the case, because, people always want to lead stuff, don't they? And yet, ultimately to make progress, we all have to go, okay, it's your turn to lead the next bit. And that's how we make progress. So many, many, many people. So the first 10 years of our research journey, we have, with the support of Beat SCAD, published 41 scientific papers, editorials, or reviews. It's not about numbers particularly, but hopefully it gives you a little bit of an idea of the breadth and scale of the things that we've been able to do. And, there will be some people in the room who will remember those early meetings and SCAD conferences. I'm not really looking down towards the front row, but you know, who will remember where the majority of patients had a delayed diagnosis or a misdiagnosis. It was incredibly common, and it still is too common, but it is less so than it was. It is definitely a more recognised thing, and you know, again, it helps the bits that we're doing, but also the bits that Beat SCAD doing going out there, because we recognise again that SCAD is something that's seen by healthcare professionals across the piece. So we need our ambulance crews to know what SCAD is. We need our obstetricians to know what SCAD is. We need our cardiac rehab colleagues to, you know, pick up the patients that the consultant forgot to refer, and all of those kind of things. So lots and lots of different things in terms of those talks, presentations, discussions. And finally, and you know, hopefully this will expand going forward, SCAD now appears as a distinct entity in the International Heart Attack Guidelines. So there is now a specific SCAD section for the first time in the latest guidelines. And you know, previously, and the previous guidelines, if you search SCAD or coronary dissection, I think it appeared twice as a sort of one sentence or something, and that was it. So what have we discovered together so far? Well, I think we have some significant achievements to thank many, many patients for, right? Because these, when we're talking about genetics, it's your DNA that we're using. When we're talking about the scans, it's your scans. And sometimes people will say, but I didn't come up for a specific research day. And sometimes that's the case. Sometimes we will do a specific research day and bring particular people up because we were interested in them. But all of your scans get used in these studies so that we understand this disease more. And so when you sign the consent form for the registry or for the other things, we're using all of that data to learn more about SCAD. So what have we discovered so far? Well, the first risk gene associated with SCAD was, you know, we were very closely involved with that. But again, you'll see, I'm not going to go through all of the names here. You'll see some of our team, but that's Tim's the Mayo Clinic, Nick's French, he's Australian, you know. And again, it's just the point that I'm trying to make, that, you know, so many people have to be involved to allow these things to happen. We produced the first study to discuss the cardiac MRI findings of SCAD, and we'll talk a little bit more about that, but that's the first time we've really had a picture as to what SCAD does in terms of the injury to the heart. The first gene sequencing study in SCAD, this is the study I mentioned a moment ago that was funded by our collaborators at AstraZeneca and enabled us to look at those rarer genes, but things that might run in families, and I'll talk about that a little bit more in a moment. And lots of novel studies that look at how SCAD develops, why does it happen, and just trying to understand that, because if we understand why it happens, maybe we can understand who's at risk, and maybe we can understand what intervention might prevent it from happening if we can. And of course, none of this would have happened without the patient community and without Beat SCAD. And I've said it before, you know, we are being very grateful for support from the BRC. We're also very grateful for the support of the British Heart Foundation at the beginning of our journey. But for the last few years, we haven't been able to secure further funding. We hope that worm might turn soon. But over the last few years, our efforts have been essentially predominantly supported by the BRC and by Beat SCAD. And without Beat SCAD, we wouldn't be here today. I wouldn't be here today talking about the research findings that have been made. So what have we learned about patient care and patient outcomes from the research? So I mentioned the CMR study, and I'm going to do a little bit of data and research, but not too heavy, hopefully, just the main messages. So the main findings of the cardiac MRI study, and the most important message, is that SCAD tends to cause smaller injuries to the heart. Not everybody, I accept, is in that situation. So there will be some people that do have bigger injuries, but the majority of patients with SCAD have smaller injuries. And you'll see, if you're looking at the graph on the right, that there are some patients there where you have an unmeasurable scar. So when you do the MRI scan, you can't see a scar, even though you know that the SCAD has occurred. And if you look at this graph here, you can see the distribution of cardiac function. And we do see some people that have more significant cardiac function. We know you're out there. We were talking a little bit earlier on about management of heart failure and things in some of the discussions that we had earlier on. But actually, most patients have very good heart function. So even if there's a scar there, the heart's performance remains very good. And so this is an important finding to tell patients. It's also really important to remember that, okay, we have to get that recurrent sting, although it's not that common, remember, as I said earlier. But even if it happens, the data suggests that you will do very well because the injuries to the heart are very small. What we have been able to do in terms of the MRA was that, yes, there are some things that we find. Occasionally, and it is occasionally, we find things that we need to do something about. So we might find some renal FMD, which is leading to blood pressure that can't be controlled, and maybe we need to do something about that. We may find a little aneurysm that needs to be treated. But those are quite uncommon, actually. More commonly, we find more minor things, sometimes things we need to keep an eye on over time, keep under surveillance. But that is the commoner thing. And most importantly of all, actual problems, vascular events, significant trouble that means you end up with a problem that you need, end up in hospital, whatever it is, seems to be really, really rare. And the follow-up period of 5 years for the patients we looked at, we didn't see any events, which tells you that, yes, those things are there. We need to look for them and understand them and make sure we're managing them appropriately. But also from a patient's perspective, this is not something to be disproportionately frightened about, okay? Because the outcomes of these things when we find them is good, okay? The PCI paper, I danced a little bit around this earlier, so I won't dwell on it. But again, this was work that was done partly in Leicester, I think, with principally Spanish colleagues, and I'm not sure whether there was anybody else in the world. I'm sorry if there was and I forgot to mention you. But again, an international effort. And I think this is also was an important message because we'd already got quite a strong feeling at this point that conservative management was the right way to go for most patients. And what happens when you find something like that and start to discuss it in the medical field is that the pendulum swings like this, and then suddenly everybody's being managed conservatively. And what we'd started to identify was that there were actually some patients with SCAD that was blocking the artery completely, where we felt that actually maybe they did need something doing to sort that artery out in that context. And so what this paper did was it said, yeah, okay, conservative management is the right way to go for most patients, but actually for some patients, balloons or sometimes stents is the right way to go. And I think that was an important contribution. And also what it said was that on the whole, the decision-making seems to be pretty good. So there will always be a case where we have a look and we think, oh, would I have gone with stents there? But on the whole, it seems that when people are reaching for balloons and stents, they're doing so because there is a set of circumstances when it's the right thing to do to reduce the risk of heart damage. And that's quite an important message as well, because I think sometimes people who have had stents were wondering whether that was really the right thing to do and have I been given the wrong treatment at the beginning. And it seems that that doesn't seem to be the case. Diagnosis, and I'm not going to go through all of the different things that can pretend to be SCAD, but this is one of the most important things, I think, for the specialist clinics, which is that there will always be a proportion of patients where it's actually not SCAD, but it's something else that we need to think about. And again, this was a paper that we published predominantly with our collaborators in the Mayo Clinic, just describing all of those things so that, again, clinicians hopefully can look at those things and go, maybe this is this type of SCAD mimic rather than real SCAD. But you can, again, understand the importance of getting the diagnosis right. Because ultimately, if somebody thinks you have SCAD, or we think you have SCAD, and we stop your statin, for example, that's fine if you have SCAD. But if actually you have conventional coronary artery disease and we've got it wrong, and it's pretending to be SCAD, then we're denying you a treatment which we know is beneficial to patients who have conventional coronary artery disease. And so it's really becomes very important to get the diagnosis right. And hopefully this work that was published has helped with that. I mentioned a little bit about the CT study, but I didn't show enough of my multicolored pictures, and I thought it was very important to put them up again. But what we're trying to do here, as I mentioned, was we're trying to say, okay, with CT scans, sometimes it's quite difficult to make the diagnosis of SCAD using that imaging technique. And yet, because we want to try and manage lots of patients with SCAD conservatively, we really would like, if we can, to have a non-invasive test. We'd like to be able to look with a scan rather than do an invasive angiogram unless we really need to. And so our question was, can we develop or can we find things that would help? And this is a tool which is very new. It's just being introduced a little bit into the NHS at the moment for conventional coronary artery disease that looks at inflammation around the artery. It's called PHI, and it's been developed by a research team in Oxford. And this is the first study that applies PHI score, which is a similar thing but includes some aspects of, who you are, to look at whether or not we can use this. And the answer is, it looks promising. Okay, we've got a little bit more. I mean, the nature of SCAD is we've looked at 43 patients or something, which in the SCAD world is huge, but in the real world is quite small. So, we need to do a lot more work on this. But hopefully you can see that the matched control case with conventional disease is yellow, so non-inflamed, whereas this one's got lots of blue and red. So it's got that inflammation. And this is, again, arises a little bit from some of the previous work that was done, supported by Mary Shepherd at St George's, looking at histology and pathology and understanding the disease from that perspective. And it's, those things can be very informative and help us. And they showed us the inflammatory reaction and the timing of the inflammatory reaction that occurs after SCAD. I should say, by the way, that inflammation then goes away. So it's not an inflammatory disease. This was something that was demonstrated in that study. It's a response to injury. It's a response to the bruise in the wall of the artery rather than an inflammatory process. From this, you've seen the graph just showing the distribution of pregnancy-associated SCAD on the top there. I think the other thing is, we have to consider the rare cases in SCAD patients of non-survivors, and it's a difficult thing to talk about, of course. It is incredibly uncommon. And remember, that's the reason, because the heart events are small, the injuries to the heart are small. But of course, occasionally that happens, and it can occasionally happen in the context of pregnancy-associated SCAD, which is obviously a terrible scenario, right? But we wanted to look at this, particularly to try to understand if there was a missed opportunity in these ladies, whether there was something that we could do to advise people to look out for something or something like that. And actually, what the data suggested was that there wasn't a missed opportunity in these ladies, that unfortunately what tended to happen was sudden and catastrophic in those very small number of patients. Remember, this is across the whole country, across a period of years, and across many, 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 many pregnancies. So this is a small thing, but it's important for us to try and learn even from those cases whether there's any opportunity for us to learn it. And then the other thing at the bottom, which is relevant, confirmed by data from the Mayo Clinic, is looking at the risk of recurrence in patients who have a subsequent pregnancy. And so as the risk of recurrence in somebody who has a subsequent pregnancy after a previous SCAD is around 9%, so around 1 in 10 chance during pregnancy and during a year afterwards. And again, these are difficult data to get our heads around, but at least it enables us to provide some sort of numbers to people who are thinking about these things. That doesn't mean pregnancy is banned or anything like that, but it does mean it needs to be thought about. It does mean it needs to be discussed. There are often individual considerations around pregnancy, and we would encourage people to engage with those discussions at the earliest opportunity, preferably before conception. So what about the why questions? Probably one of the commonest questions in clinic is, why did I have SCAD? And we still have lots of things to answer, but we have made some progress here. So the OCT study, again, you've seen this already, but this is one of my favourites because there was a guy called Rob Jackson who spent a protracted period of his life drawing circles around these OCT images. And what he noticed, or what we wondered about, the first thing was that there did not seem to be a connection between the area in the wall of the artery and the area where the blood is flowing. And this was important because before that, we were thinking that maybe all of SCAD was due to a disruption in the wall that enabled blood to enter into it. And what Rob's work did was, first of all, demonstrate that isn't always the case. But also, by drawing all of these circles, what he showed was that the outside of the vessel in SCAD is actually expanded, the little membrane in between is squashed, and the true lumen is smaller where there is no connection. And what that told us was that what's actually happening is you've got this bruise that is pressurized, because it's the pressure in the bruise that causes the intimal medial membrane, that little bit between the two sections, to be thinner and the vessel to be smaller. And so that enabled us to come up with this, if you like, new paradigm, or at least to confirm this was the likeliest scenario, that the problem is in the wall of the artery, and that the connections develop from the outside in rather than from the inside out. And these are all small itty steps, but what that then means is that our focus is then on the wall of the artery. We're not thinking about what might cause a disruption of the wall of the surface. We're thinking about the wall of the artery. I've mentioned a little bit about the pathology study, some aspects of it. One of the other elements of that, and some of the other research that we've been doing more recently, has been using little pieces of skin that some of you provided in the past, and hopefully some of you may provide again, that allow us to look at particularly those bits of the glue that holds cells together. We call that the connective tissue. And those little circles that you can see in F and G here, these are little collagen fibres, and we were looking at the collagen fibres, this is using electron microscopy, so this is super magnified. And what essentially that showed is that there wasn't a gross change in the numbers, the shape of these fibres, and we were interested in that because that's been shown in some of the inherited connective tissue disorders that these biopsies look different, but it doesn't seem that that's the case in SCAD. There were a few little hints of things that looked a bit different in terms of just fraying of some of the elastin fibres and things like that. So in some respects, it tells us a little bit where not to look, that the problem is more subtle than just a gross structural change to the connective tissue. And some of the genetics has maybe suggested a little bit more about what that may be about. Another common question in clinic is, what about my kids? The first key study on this was again done by the Mayo Clinic, and what they showed is that SCAD is not a strongly familial condition. So familial SCAD, it does occasionally occur, but it is very rare. What we did was to do a gene sequencing study. So again, all those you gave your blood, that DNA was whisked off. The DNA was extracted, and then our collaborators at AstraZeneca did their very expensive sequencing of those genes. And what we found was that the sorts of genetic abnormalities that run through families are very uncommon. So we found them in 3.6%, there you go, of patients who were included in this study. So that's a tiny proportion. And of those patients, the majority seem to have genetic abnormalities that are associated with other known syndromes. So the commonest gene that was found was the adult polycystic kidney disease gene. So that's known to be associated with SCAD in some patients. And then there are a few other conditions, vascular Ehlers-Danlos syndrome you've heard about a little bit before, Louis-Dietz syndrome and Marfan syndrome. So these are uncommon syndromes, but they are conditions that will generally have a family history of things. And what this does is it helps us because, first of all, any of you that have been to either of the SCAD clinics, you'll know that we ask you about your family and what we know about them, and that's part of the reason why. And also when we're scanning, we're looking on the scans to see whether there's something a bit unusual, whether you have aneurysms in different places where we might go, that's a little bit unusual. But for most people, what this study says is it's fine. We don't need to do genetic testing in people who have sporadic SCAD, who don't have a family history and who don't have anything on their imaging which suggests that they might have an underlying hereditary connective tissue disorder, one of those syndromes that I was talking about before. So this was incredibly useful. We want to do more gene sequencing, and we're constantly flirting with anybody who is in industry or elsewhere who has the resources to be able to do it. It's an expensive thing to do for universities, but we keep looking out there to try and make those relationships like we made with AstraZeneca to make this happen. So then there is the GWAS, the Genome-Wide Association Study. So what's going on here? So what we were talking about in the gene sequencing study was looking at what we call rare variants. Now these are rare abnormalities. And the point about rare genetic mutations is that those are the ones that get inherited in a family. They might move through a family, and that's why they cause these rare genetic syndromes. What we're talking about here is common genetic variants. So we all have all of the genes that we have. And actually, the reason that you aren't all clones of me, thank goodness for you, is because you have differences between your genes. And what this GWAS is asking is, are there variations in all of those genes that you have that confer a risk of SCAD? And the answer is, yes, there are. And actually that these do seem to contribute a fair amount to who gets SCAD and who doesn't. So these are common genes, remember. So I have these genes, everybody has these genes. It's just the variants, and then it's the combination of variants that confers your risk. So maybe one of these genes might give you a little bit more risk, but maybe if you have 5, that gives you a bit more risk. And if you have 25, 50, that gives you a bit more risk. And, these things will be not the whole story, but they're contributing to why some people are more likely to get SCAD than others. So again, I think, as I said earlier, the big news for me for the GWAS was just how amazing everybody internationally was in contributing to this. And so what it discovered, so way back, we were talking about factor 1, which is there. So that was the first common genetic variant that we and others identified, and now we have 16. That helps us enormously, first of all, because these genes tell us a little bit about what makes people more vulnerable to SCAD. So you heard a bit about factor 1, which is a gene that's associated also with the risk of migraine, fibromuscular dysplasia, carotid artery dissection. So things that we know make a bit of sense. We've also got genes in here, FBN1, that's associated with Marfan syndrome, and that's one of the syndromes. Now this is a common variant, so this is the thing that everybody has, but rare variants in this gene, which cause more severe changes to how that gene is working, cause a Marfan syndrome, which we know is associated with SCAD. And here we've got 2 pieces of collagen 4 that's involved. And when you look across the spectrum of these genes, don't worry, I'm not going to test you at the end to see how many of them you can remember. But the most important thing is what they show us is that SCAD is about the glue that holds together the tissues. It's about how connective tissue is held together. It's about adhesion, about how things are stuck together and held together. And generally speaking, if you have a little bit more of a loose arrangement, it makes you a bit more vulnerable to SCAD, which makes sense, right? Because we remember that it's that separation of the wall of the artery, and it makes sense that if you have a little bit more movement in the wall of the artery, that you might be more vulnerable to it. And the other one, which is F3 here, this is something called tissue factor, and this is involved in clotting in the wall of the artery. Well, not the wall of the artery, it's actually involved in tissue-mediated clotting. But from a SCAD perspective, it makes sense because we've got a bruise in the wall of an artery. And so something that mediates clotting in the wall of an artery makes a lot of sense as to something that might be important for a condition such as SCAD. So this, I hope, is giving you an idea of why the GWAS is so important, because it gives us this whole bunch of clues, and it also gives us a whole bunch of target proteins that we can then investigate further to really try to understand the underlying cause of the disease. So part of the next stage of the research that we want to do in patients is we want to look at patients who have different genes, both with and without different genes, and see what that does to your arteries when we do our MRI scans, ultrasound scans, things like that. What happens to people with different genes who maybe are at different points in the menstrual cycle? How do all of these things interact with a patient to make you more vulnerable? And also at a cellular level, what are they actually doing? What do they change and how do they change it? Because of course, again, if we understand how that works, we might be starting to get towards understanding how to be able to modify that in a way that's favourable to patients. The other thing that was really exciting and interesting in the Genome-Wide Association Study paper is that, again, do you remember what we said about factor 1 making sense because of how it associated? Well, actually, when you look across all 16 genes, they also all fit into the same pattern, which is that if you look over here, this is coronary, so anything to the right of this line is an association, so it means it's linked to it. Anything on this side means it's opposite to it. You can see here, this is coronary dissection, fibromuscular dysplasia, migraine. Well, the reason so many of you got migraines is because the genes that confer risk of SCAD also confer risk of migraine. Yes? Blood pressure, systolic blood pressure, diastolic blood pressure. So actually, the reason some of you have high blood pressure, not all of you, it's again, remember that these are common genes, not all of you will have all of them. But the reason some of you have high blood pressure is probably because the genes that are associated with the risk of SCAD also are associated with high blood pressure. So it links and it makes sense. These are different things, but the most important thing down here is conventional coronary artery disease. And what this shows you is that SCAD patients and patients who have this genetic profile of SCAD are actually protected a little bit against conventional coronary artery disease. And this makes sense because for years we've been looking at the coronary angiograms of patients with SCAD. And one of the ways in which we work out whether you've got SCAD or not is that we look for conventional coronary artery disease and go, there isn't any, so I think that might be SCAD. And now the genetics is fitting with that observation and saying, well, actually, there's perhaps a reason why. That these genes that unfortunately confer a risk of SCAD actually protect you against another type of disease. And that's a bit of a bonus, isn't it? Because if you've had SCAD, it's nice to think you might not get something else, right? So these are important and interesting findings that give us a whole lot of avenues for where to go next. So this is just some of the things, and it all depends on how much funding we can bring in from British Heart Foundation, and also the support of Beat SCAD is critical to all of these things always. So just some of the things that we want to know. We want to understand what these genes do to the artery that makes it vulnerable. And that starts at the cell, What does it do to a cell that then affects the wall of the artery, which is a bunch of cells that makes patients vulnerable? How does that interact with those sex hormones? Despite all of this genetics work that we've done, I was expecting something that related to female sex hormones to come out from this. I was expecting to look at it and go, there it is. No. So we've still got to explain that. It may be that the female sex hormone story is not a genetic-related issue, it's a something else-related issue. The other thing to say is that the 16 genes, we reckon it's about a quarter of the genes that have a responsibility for SCAD. So again, there's a journey to go down. In this study, there were 2,500 patients that contributed. We need to get that up to tenfold. And then that will give us another group of genes to understand, and another whole bit of the story opens up. Other things, we want to understand the role of emotional stress in SCAD and post-SCAD chest pain. We have made some progress. Alice has been doing an amazing work on male SCAD, trying to understand the similarities, differences, vulnerabilities of men with SCAD. And men are, as I said earlier, you are fantastic, you chaps, because you don't have cycling hormones to mess everything up when we do an experiment. So go the male SCADs. improving early diagnosis. You've seen about the CT stuff. I haven't shown you a little bit of the stuff that we've done looking at some blood markers. We've done a little bit of work looking at urine biomarkers as well. It's looking quite promising. That's with our Belgian collaborators again, have been helping us with that side of things. You've heard about the exercise story. We are so excited about this, working with our colleagues to understand the exercise thing so that I don't have to flannel when you ask me the heart rate question. So I can actually say, well, actually, look, we've got it. Here's the data. We've measured it. We've looked at it. This is what we think is entirely safe. This is what we think you shouldn't be doing. And just understanding that rehabilitation journey is going to be really important, because I don't think really that's been described in any heart condition, let alone SCAD, and we're very excited about that. And again, we've got a grant in that we've got our fingers and toes crossed. I've got so many fingers and toes crossed I can't walk most of the time. The psychological impacts of SCAD, we've mentioned that that's again an international effort. And I've said a little bit earlier on that I think it's an area that we haven't done enough on, and we're probably not still doing enough on in terms of the clinical service that we provide. So that's definitely a mission. And I said earlier, clinical trials have begun, and clinical trials will give us things that enable us to give you firm answers to questions. We're never going to be able to answer everything, because one of the challenges with clinical trials in SCAD is that you need a lot of people to be able to answer the question. But with time and with international collaboration, we will be able to answer some of these questions. In terms of actually doing the research, I stand here and talk a good game, whilst basically other people do all of the hard work. And in terms of the next stages of the research that we hope to do, we are very excited that Beat SCAD have managed to raise the funding for us to have a new clinical fellow who will be working with me in Leicester. Now, I'm not expecting her to deliver on all of the things that I've just said, just most of them. But I did just want to introduce you to Anju, just so that you've met her, because she's marvellous and we're really looking forward to it. It's called Baptism of Fire.
Thank you. So I've been working as a cardiology registrar for over a few years now, and I've had the opportunity to look after a few patients with SCAD. And I've also seen some of your stories on the YouTube channel, which has actually inspired and motivated me to pick up this post. And I'm really looking forward to working with Dr. Adlam and his team, who actually do excellent work and perform life-saving research. Thanks.
Was it on? Did everyone hear it? You heard that. So that was my fault, because I was supposed to switch it on. So actually, the other thing, now that I have switched the mic on, was I did want to expend a moment to just for Abby just to say hello and all of that stuff. Abby has been very much part of the SCAD journey from the very beginning, and runs a very important SCAD service in London for our patients, and many of you will know her already, but I just wanted to make sure that she had a moment in the blue light of my slide to say
thank you, Dave. Yeah. Thank you. It's wonderful to be here. It's actually lovely to be here. It feels like this is exactly the journey I started many years ago when I met Dave, and inspired by lots of the SCAD patients. So thank you for inviting me back here, and thank you for Dave for welcoming me back here. As you know, the SCAD clinic in London is there. I'm very sorry the waiting list is forever for most of you. I know I get 1,000 emails, and I try to answer them as much as I can, and there is always delay. But do feel free to email, to pester me, to tell me that you haven't had your scans and that you need to be seen earlier if you're running into problems. And we're here to support you. And I'm hoping with the new expansion in London, it just does reduce the waiting time to support you. And hopefully, between all of us, we can improve SCAD care across the UK.
Thank you.